Okay.
Good morning, everyone. I am Jeb Bradley of Senate District 3. Today we are holding a meeting of the Senate Health and Human Services Committee. Before we get started, I want to read through a checklist to ensure the meeting we are holding is in compliance with the right to know law. As chair of the Senate Health and Human Services Committee, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic and in accordance with the governor's emergency order number 12 pursuant to Executive Order 2020-04 and its extensions, this public body is authorized to meet electronically. Please note that there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to the governor's emergency order. In accordance with the emergency order, I am confirming that we are, number one, providing public access to the meeting by telephone with additional access possible by video and other electronic means. We are utilizing Zoom for this electronic meeting. All members of the committee and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform, and the public has access to contemporaneously watch and or listen to the meeting on Zoom or YouTube and via phone by following the directions and links provided on the General Court website. 2, we have provided public notice of the necessary information for accessing the meeting in the Senate calendar. 3, we're providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remote Senate, that is remote Senate, all one word, at leg.state.nh.us, or you may call 603-271-6931. In the event the public is unable to access the meeting, it will be adjourned and rescheduled. 5, please note all votes taken during this meeting shall be done by a roll call vote. 6, finally, let's start the meeting by taking roll call attendance. When each member states their presence, please also state where they are and if anyone else is in the room with you during this meeting, which is required under the right to know law. So I'll start with the roll. Senator Avard.
Senator Avard here in my office in Nashua. I am alone in the house and do have some loud puppies.
Senator Whitley.
Good morning, Senator Becky Whitley. I'm in my home in Hopkinton and I'm alone in the house.
Senator Sherman.
Senator Tom Sherman. I am in my home in Rye. I'm alone in the room, but there are other family in the house.
Senator Gray.
I am James Gray. I'm Senator from District 6, and I'm at my home in Rochester, and I am alone in this room.
And I'm Jeb Bradley, and I am in my office in the State House on the 3rd floor, alone in the room. Okay, so I want to open the hearing on our first bill this morning, which is House Bill 89. And Griffin, Kirsten, if you can see if Representative Vale is available to introduce this bill.
And I just brought her in.
Okay. Good morning, Representative. How are you?
I am fine, thank you, and I hope you all are well as well. Good morning, Mr. Chair and Senators of the Health and Human Services Committee. I am Representative Suzanne Vale, and I represent Nashua, Ward 3, Hillsborough County, District 30. I'm here today to present House Bill 89, an act that adds moderate to severe insomnia and autism spectrum disorders to the qualifying conditions of the state of New Hampshire's therapeutic cannabis program. Moderate to severe program was, moderate to severe insomnia was approved last year by the Therapeutic Cannabis Medical Oversight Board as a qualifying condition for application to the program. That bill passed, but it never made it to the Senate during the state of emergency. I'm going to speak a little bit about the moderate to severe insomnia, and Representative Knirk will follow behind me with some more information about insomnia, as well as the application of the program to autism spectrum disorder. As a member of the Therapeutic Cannabis Medical Oversight Board, he will be most likely best equipped to take the difficult questions. Moderate to severe insomnia is related to mental illness, anxiety, agitation, depressed mood, and increased prevalence of nightmares. It causes moderate to severe physical stress on every system in the body, exacerbating chronic illnesses such as Crohn's disease, for an example. The prevalence of insomnia is widespread, occurring in 10 to 30% of the general population, according to the National Institute of Health. I believe that right now we can assume there are more cases of insomnia than ever due to the stress of the pandemic and the state of the emergency, the uncertainty, and the profound effect of massive loss of life that we've experienced. Traditional sleep medicine, unfortunately, can be habit forming and cause side effects such as tolerance, excessive dryness, dizziness, and using over-the-counter sleep aids don't provide relief from those side effects. With tolerance, addiction, sleepwalking, sleep driving, sleep eating, patients are cautioned and directed to not drive the next day following the use of certain medicines. Older compounds are almost unilaterally habit-forming, addictive, and they lose their effect over time. The cannabis products come in forms that have no lingering side effects. And when CBD is isolated from THC, the cannabinoid part of the molecule, there's no psychoactive component in the product. There are many choices and many ways to treat insomnia with the products at the alternative treatment centers. And what we have found is that many of the patients who come to the treatment centers for the treatment of Crohn's disease and other major illnesses find that their sleep greatly benefits. And those who consider nightmares to be an essential part of the problem have been able to find appropriate dosages of the THC, which also combats additional symptoms of PTSD by its ability to affect the sleep architecture. Those who can stay asleep, fall asleep, stop waking up early, generally achieve a better quality of life, as we know from our own experience. In summary, New Hampshire, we have this closed system that offers alternative treatment. All the cannabis products are controlled, tested, measured, dosed, packed into tamper-proof containers. These products are available in many forms in order to address an individual's experience of symptoms that lead to chronic illnesses and that are from the chronic illness. And we cannot find this level of purity and integrity out in the community. And so when people are forced to treat symptoms with products of unknown origin, yet bear the label of known compounds, cannabis components such as the cannabinoid CBD, they'll take it because they want to sleep. And treating this before we know what the cause is and what we're using is not an appropriate alternative for New Hampshire people. Thank you for listening to my comments in support of the bill. I do want to point out there's a fiscal note included with the bill that shows that there would be an indeterminate increase in revenue due to the increase in applications to the therapeutic cannabis program.
Thank you, Representative Vale. Are there questions of Representative Vale? Seeing none. Thank you very much.
Thank you.
So the next person I have signed up wishing to speak is Representative Jerry Knirk.
Okay. Good morning, Representative Knirk.
Good morning, Senator Bradley and the committee. Can you hear me okay?
Yep.
All right. Yes, I'm Representative Jerry Knirk. I represent Carroll County District 3, and I also serve as the chair of the Therapeutic Cannabis Medical Oversight Board. HB 89 as amended adds moderate to severe insomnia as a qualifying symptom and autism spectrum disorder, which I will refer to as ASD for ease, as a standalone qualifying condition in the therapeutic cannabis program. The board of the TCMOB is composed of the Chief Medical Officer of DHHS, a qualifying patient representative, a clinical representative from an ATC, and 10 medical providers from various fields. We're charged with the task of advising the therapeutic cannabis program on medical issues, including qualifying conditions. We consider each qualifying condition with an exhaustive literature review, a public hearing, personal experience, and robust discussions. As reported by Representative Vail, we voted 9-1 to recommend the addition of moderate to severe insomnia last year for the bill, which then died a COVID death. Many currently available pharmacological treatments for insomnia and primary sleep disorders are limited by side effects and in some cases addiction liability. The benefits for some of these prescription medications are really noted to be rather minimal, like just decreasing sleep latency by maybe 7 minutes and increasing total sleep time by maybe only 15 minutes. And they often come with increased risks of next day drowsiness, confusion, traffic accidents, hallucinations, sleep paralysis. Now, the thing is, cannabis is not without any risk, and it does have side effects as well. So we do have to keep in mind that the dosing on that has to be very carefully monitored. But the majority of the studies suggest that the use of THC and THC derivatives, either alone or in combination with CBD, may improve self-reported sleep quality, decrease sleep disturbances, decrease sleep onset latency. That's how long it is before you go to sleep. And now the studies are limited, but they overall point to more beneficial effects than deleterious. Some medications we currently use to treat insomnia can really mess up and adversely affect your sleep architecture, like the REM sleep and the deep sleep. At least one study showed that the cannabinoids may have fewer effects on sleep architecture than traditional medications. But the particular preparation and dosage of cannabinoids will be an important factor in that, and more research is needed. Now, as Representative Vail pointed out, insomnia can often be associated with other primary disorders. And it is for that reason that TCMOB recommended approval of insomnia as an associated symptom rather than a standalone condition, because the primary issue should also be addressed. Improving sleep habits and behavioral therapy should always still be the first line of treatments, but TCMOB feels that the therapeutic cannabis is a reasonable alternative when those do not suffice. Now, HB 89 was amended, and I also serve on Health, Human Services, Elderly Affairs, by the way. And HB 89 was amended in House HHSEA to add ASD. This was a result of work that TCMOB did last year, evaluating SB 700, which aimed to add ASD as a qualifying condition, but it never made it through the process either. And we were surprised when Senator Reagan did not file it again, and the board agreed it would be reasonable to offer an amendment to HB 89 with the agreement of the sponsor to add ASD as a standalone condition. Now, the thing is that agitation and other problems in ASD, particularly in adult patients, can be difficult to manage with current pharmacological options. You know, we've all had, or many of us have had a 3-year-old having a meltdown in the aisle of a supermarket, and you can kind of deal with it. But if they're 23, that's a little harder. And so it's really difficult sometimes to manage some of the behavioral issues. Anecdotal evidence and emerging literature support cannabis as a reasonable option in the management of ASD. And there are studies underway looking specifically at the use of therapeutic cannabis in ASD, but strong evidence is currently lacking. Testimony at the hearing and written testimony provided compelling anecdotal evidence of the usefulness in treating agitation seen in individuals with ASD and the desperation of patients and caregivers with such behavior. Now, we do know that there are significant risks in the use of cannabis in the developing brain. We also don't even know what those risks necessarily are in autism, because autistic brains are probably wired a little bit different than a regular non-autistic brain. But the point is, because of those concerns, TCMOB decided to add some fairly strict guardrails. We felt that we should have certification of patients under 21 requiring evaluation by a provider of child or adolescent psychiatry, pediatric neurology, or developmental pediatrics who confirms that the ASD has not responded to previously prescribed medication, or that other treatment options produced significant side effects, and that provider supports certification for the use of therapeutic cannabis. We recognize there are not a lot of those providers, but we also feel that this is an area where care should be managed. And this is one of the basic things that we do in TCMOB is we work hard on a question until we can come to a consensus that we not only feel something helps, but we have significant guardrails in place to make sure that it's going to be done correctly. So the bottom line is TCMOB urges the passage of HB 89. And so thank you, and I'd be glad to take any questions if anybody has any.
Are there questions of Representative Knirk? Seeing none. Thank you very much.
You're welcome.
So that is all the, that's all the people I had signed up to speak on this bill. If there's anybody else who wishes to speak, please raise your hand or press *9 if you're calling in on the phone. And I'm not seeing any hands, Senator.
Great. Since the next hearing's at 8:45. So we'll close the hearing on House Bill 89 and open the hearing on House Bill 163 and recognize the sponsor, Representative Marsh.
Good morning, Senators. Can you hear me?
Yep, good to go.
Very good. For the record, I'm Representative William Marsh, representing 7 towns in Southern Carroll County, and I'm pleased today to offer for your consideration House Bill 163 relative to cannabis use during pregnancy. This bill is very similar to last year's House Bill 1591, which died a COVID death. House Bill 163 directs DHHS to create a poster and make information available at the dispensaries regarding the use of cannabis while pregnant or lactating, about accidental poisonings, and about use during adolescence. This parallels the information currently being made available in Colorado dispensaries. As cannabis has been made available for therapeutic use by the general court and not by the FDA, it becomes incumbent upon the general court to provide consumers with information, just like the FDA provides package inserts for prescription drugs. We know from a June 2019 study in JAMA that the rate of preterm birth among reported cannabis users was 12% versus 6% in non-users. We also know from a June 2018 study in obstetrics gynecology that 69% of dispensaries in Colorado recommend cannabis for first trimester morning sickness. Surgeon General Jerome Adams has expressed concern about subsequent learning disabilities and about the risk of accidental poisonings, particularly with edibles. The amendment we adopted in HHS and Elderly Affairs clarified language as recommended by the Therapeutic Cannabis Medical Oversight Board. I thank you, and I'll be happy to take questions.
Are there questions of Representative Marsh? Seeing none.
Thank you.
Next person I have signed up wishing to speak is Representative Jerry Knirk.
This is Carroll County Day. Good morning,
Yeah.
Representative Knirk.
Yes, that's what I was going to say. It's Carroll County Day. This is the Bill, Jeb, and Jerry show. But anyway, here's the point. By the way, y'all can hear me okay?
We're good.
Okay, good. So once again, I am the chair of the Therapeutic Cannabis Medical Oversight Board. For the record, I'm Representative Jerry Knirk, representing Carroll County District 3. And indeed, I've already told you what TCMOB is, so I won't go over that again. And as Representative Marsh has already pointed out, it talks about what that HB 163 adds these requirements for educational materials regarding use of cannabis in pregnancy or adolescence. And this is a concept that is supported by TCMOB. First, I do need to point out that the Surgeon General's report had to do with cannabis in general, not just therapeutic cannabis. The great majority of users who are pregnant or adolescents are recreational users. The data regarding cannabis risks comes from recreational cannabis users, as the therapeutic cannabis literature is just emerging. And the risks of therapeutic use may be different than in recreational use, because of different patterns of use and dosage. Remember, the goal of using cannabis in the therapeutic setting is different from the goal in recreational use. In therapeutic cannabis, we're not using it to get high, but instead to treat a condition. Doses are titrated using the rubric low and slow. You start with a low dose and slowly build to achieve the therapeutic effect while minimizing the side effect of euphoria. So this may change some, but still these concerns are real and they do need to be taken care of. It's also important to understand that the peak ages for certified patients in New Hampshire therapeutic cannabis program is in the ages of 50s and 60s. Out of 10,688 total qualifying patients in the TCP, there are only about 325 between ages 18 and 25, and about 1,500 in childbearing age. Now, one of the main goals for TCMOB in 2020 was to develop educational materials, both for patients and providers. We have already developed educational sheets regarding the risks of cannabis use during pregnancy and lactation, both for providers and patients. And we're ready to proceed with the implementation of these educational initiatives. We also have already discussed and recognized the risks of cannabis use in adolescents, and we've already developed educational slides for providers regarding these risks. We already have some issues in place regarding accidental poisoning in terms of not using attractive packaging for edibles and having sealed containers, and there's also information given about poisoning, but we agree with the concept of a poster to increase that message. So the point is that TCMOB supported the 2020 version of the bill, HB 1591, by a vote of 9-1. We reviewed the language of 163, including the new language regarding adolescents, in our February 2021 meeting. We supported the concerns and support the bill, and we came to consensus on some suggested changes, which were added by amendment. So TCMOB does urge the passage of HB 163, and I'd also be glad to answer any questions if you have them.
Questions of Representative Knirk? Seeing none. Thank you very much, Jerry.
You're welcome. Thank you.
Senator, that was our last person signed up to speak on House Bill 163. If there's anybody else who wishes, to speak on this bill, please raise your hand. I got nobody, Senator.
Okay, so I'm going to close the hearing on House Bill 163. We have 7 minutes. I think I would entertain a motion to go into executive session.
So moved.
Senator Gray has moved that we go into executive session, seconded by
Senator Avard.
Senator Avard. I'll call the roll. Senator Avard.
Yes.
Senator Gray. Senator Gray.
Yes.
Senator Whitley.
Is Tom available?
Yes.
Okay, yes.
And Senator Sherman.
Yes.
Okay, and I vote yes too. So I think, is there a motion on the 2 prior bills, 89 and 163?
Can we do a group ought to pass?
No. I'd like to, but we can't.
I'll move House Bill 89 ought to pass.
All right, Senator Gray has moved 89 ought to pass, seconded by
I'll second.
Senator Sherman. Any discussion? All in favor?
Just one thing of a discussion.
Yep.
Again, both of these bills are New Hampshire taking on obligations that should be handled at the federal level. If marijuana is not a class 1 drug, as the definition is, that the federal people ought to be taking action on it, and then our action on these 2 bills would be
moot.
Very much so. Thank you.
All right, any further discussion? Okay, there's a motion of ought to pass. Senator Sherman.
Yes.
Senator Gray.
Yes.
Senator Avard.
Yes.
Senator Whitley.
Yes.
And I vote yes. Is there a subsequent motion?
Consent.
Senator Gray moves consent, seconded by Senator Sherman. Senator Whitley,
Yes.
Senator Sherman,
Yes.
Senator Gray,
Yes.
Senator Avard,
Yes.
and I vote yes. All right, so we'll have Senator Avard take this one out. Okay, is there a motion on?
Move lots pass on 163.
Second.
So it's been moved by Senator Gray, seconded by Senator Sherman. We'll start with Senator Whitley,
Yes.
Senator Sherman,
Yes.
Senator Gray,
Yes.
Senator Avard,
Yes.
and I vote yes. Subsequent motion,
The consent.
Senator Avard moves consent, seconded by Senator Gray. Senator Avard,
Yes.
Senator Whitley,
Yes.
Senator Sherman,
Yes.
Senator Gray,
Yes.
and I vote yes. All right, so we'll have Senator Whitley take that one out. Okay, we have 4 minutes. Griffin, is Representative Marsh still on the
He is.
call? Could you bring him in, and could we put up the amendment on House Bill 120?
Hold on. Oh, I'm in energy. Sorry, 1 second.
We love your devotion.
Let's see. I think I have it. It's your amendment, Senator Bradley, correct?
It's my amendment, yep, that was worked on by Representative Marsh with Mike Skibby and Maura O'Neill, I believe. So, Bill, do you want to explain it for everybody while we have a few minutes?
Yes, I'll be glad to. Just pulling up what I have here. The first thing is there was concern that the definition of medication restraint was somewhat different than the definition in 126U. And we did try to correct that in 4 places in this bill. In your amendment, you have left in the language without a clinical diagnosis, which is certainly fine with me, but that language is not in 126U. There were some concerns as to whether that might reduce reporting of people who have psychotropic medications when a clinical diagnosis is present, even though that may be allowed. So that's certainly something that can be discussed. But otherwise, we've brought that definition in line with the definition that's in 126U. The second thing that we did is we took the language out of 169B23 that was added by Children and Family Law. We considered putting it in the 3 separate sections of the law, but the department felt it would be best if we put it in a new subparagraph 170G(H)(4), which is at the end of the amendment. The last change here is the reporting requirements in section 9 have were felt by DCYF to be somewhat onerous and would be difficult for them to comply with. And at their request, we removed those reporting requirements. So that's the short version of what we did with this amendment.
Okay, Bill, could you take us back to the first point where the diagnosis language remains in the bill and just show us where it is?
Yes, that is in section 1. I've got to find the line there to line 8. If you slide down a bit.
Yeah, without a, okay, I see it.
Yes.
And is that only in that definition?
No, there's the definition is repeated 4 times and it's in all 4 of them identically.
And was the consensus of the folks that you were working with that it should stay in, or is that just your view that it should stay in?
I am actually happy going either way with that. I actually believe that the child advocate's point that even if the use of such medications with a clinical diagnosis is appropriate and allowed, that the reporting ought to happen, and the reporting requirements in 126U would be would not happen if we left that definition in. So I'm actually persuaded mostly by the arguments of the child advocate on that regard.
To leave it as is now.
No, her argument was to take out the without
Take
a
it
clinical
out.
diagnosis.
All right.
That way reporting happened.
Okay. All right. Is everybody clear on that? Does anybody have questions of Representative Marsh? Okay. Do we want to take this up right now?
Do you need,
Do we want to, Senator Sherman, do we want to remove the language in 4 places without a clinical diagnosis for the purpose of immediate control of behavior? Which Representative Marsh has indicated is a recommendation of the child advocate.
yeah, I think we should do that as a committee amendment to the amendment.
Is everybody okay? We ready to proceed, or do you want to come back to this?
No, that's fine.
Jim, Kevin?
I'm fine with it.
Yeah.
Okay, so Senator Sherman has moved the Bradley amendment, which is, hang on, here we go, 1166, but in 4 places, starting on line 8, taking out the phrase without a clinical diagnosis for the purpose of immediate control of behavior. Okay, Griffin, Kirsten, you're clear on what we're doing here?
Senator Bradley, the recommendation was to just remove without a clinical diagnosis and leave the for the purpose of immediate control of behavior, because that's in 126U.
Thank you, Bill. Thank you. Okay, so Senator Sherman's amendment is to remove the phrase without a clinical diagnosis.
Correct.
Okay. Everybody clear on that?
Yep.
All right, I'll call the roll on the amendment. Senator Sherman,
Yes,
Senator Whitley,
Yes.
Senator Gray,
Yes.
Senator Avard,
Yes.
and I vote yes. Okay. We have an amendment. Senator Sherman has moved ought to pass as amended.
A second.
Seconded by Senator Whitley. Discussion. Okay, Senator Avard,
Yes.
Senator Gray,
Yes.
Senator Whitley,
Yes.
Senator Sherman.
Yep.
I vote yes. Is there a subsequent motion?
consent.
Done.
Senator Gray has moved consent, seconded by Senator Sherman. Senator Avard,
Yes.
Senator Whitley,
Yes.
Senator Gray,
Yes.
Senator Sherman.
Yep.
I vote yes, and we'll let Senator Sherman take this one out.
Yep.
Thank you very much. All right, Senator Sherman moves that we come out of exec, seconded by Senator Gray. Senator Sherman,
Yes,
Senator Avard,
You're
Yes.
just a puppet, Senator Sherman, this morning.
Senator Gray,
Yes.
Senator Whitley.
Yes.
All right. Okay. Hey, we've done 3 bills today. We're
Good
going
work, Chairman.
good. All right. So, the time being 9:03, with apologies to Representative Conley for being slightly delayed. We'll open the hearing on House Bill 605 and recognize Representative Conley.
I do not see Representative Conley in the attendees list, but I think Representative Knark might be introducing on his behalf, so I'll bring him in.
Okay. Good morning, Representative Knirk.
Good
Again.
morning again. And actually, I am, I was not intending to actually introduce, but to testify, but I'd be glad to introduce because I actually adopted this bill and took it over. Again, for the record, Jerry Knirk, Carroll County District 3, and the chair of the Therapeutic Cannabis Medical Oversight Board. Actually, HB 605 was an omnibus bill that came in with a whole bunch of leftovers from last year that died COVID deaths. Many of these were represented in other bills, some in the Senate, some in the House. And so in HHSEA, we stripped all of those out and we left in the two different pieces. So the first part of 605 adds opioid use disorder as a standalone qualifying condition for the use of therapeutic cannabis, but with very restrictive guardrails set by TCMOB. The second part allows patients visiting New Hampshire who have qualified for the use of therapeutic cannabis in their home state or Canada, which has a nationwide therapeutic cannabis program, to purchase therapeutic cannabis at a New Hampshire ATC. Now, I've already told you about what TCMOB is, so I'm not going to go over that again, but I would say that when dealing with qualifying conditions, I strive to lead this board to a consensus, because a split recommendation does not convey much useful advice to the legislature. And I will say that this is difficult, given that the board is composed of individuals with very differing views on the role of therapeutic cannabis, including providers who initially opposed the therapeutic cannabis program. So when we come to consensus, you can be pretty sure that we've explored every option and done a lot of work on it. Now, TCMOB actually includes some providers that practice addiction medicine. And we exhaustively reviewed the literature on the use of therapeutic cannabis in treating OUD, or opioid use disorder. There is evidence for the use of therapeutic cannabis in OUD, but such use is really complicated because THC, which is the psychoactive component, stimulates reward centers and therefore can actually exacerbate OUD. However, CBD, the other major cannabinoid in cannabis, has been shown to help with symptoms of craving and withdrawal, one of the most difficult things to deal with as a person is trying to come off their opioid. So given that therapeutic use of cannabis in OUD is complicated, TCMOB does not support the general use of therapeutic cannabis for OUD. They support it only when it is used as part of a specialist guided treatment program for OUD. So by a 9-0 vote, and it took us a long time to get there, we were only split last year, TCMOB approved certification of a patient for the use of therapeutic cannabis only when certified by a board-certified addiction medicine or addiction psychiatry provider who is actually the one who is actively treating the patient for OUD and to treat the associated symptoms of craving and withdrawal. This will keep it from being used widely. It'll be just used by a very highly specialized provider who will have those skills to give specific instructions to the ATC regarding the ratio of CBD to THC in the product to be dispensed and to closely monitor the patient. Now, the second part of the bill allows patients visiting New Hampshire who've been qualified for use of therapeutic cannabis in their home state to purchase, as I mentioned. There are a lot of qualified patients from other states or from Canada who stay in New Hampshire for extended times, vacationing or at a second home or as students. And this bill will allow those visiting qualifying patients to purchase therapeutic cannabis at a New Hampshire ATC so that they do not need to bring cannabis across either a state or an international border, both of which are illegal to do. The therapeutic cannabis program will develop rules for the ATCs to assist them in verifying the visiting qualifying patient's registry identification card or its equivalent. Currently, the various states swap copies of their cards so they know what they look like from other states, and we'll just make this a little more formal, and each ATC will therefore be guided and know what is a valid card. So the TCMOB rather resoundingly also supports HB 605, and I'd be glad to take any questions.
Are there questions of Representative Knirk? Senator Sherman.
Yeah. Hi, Jerry. Thank you for joining
Hi,
us.
Tom.
I have a, the role of the certifying provider has always been just to certify in order to be sure that we're not in a role of prescribing. Does that first section on opioid use disorder, it does not, this is kind of a negative question, it does not put the provider in a prescribing role, does it?
Well, I don't think so, but you're right. It kind of comes up right to the line. The issue is not so much that they're, prescribing, by the way, I should say, at this point in time, any certifying provider can instruct the ATC as to what product they wish the patient to get. So for example, you may have a patient who has pretty bad lung disease, and you maybe say, look, I want this patient to get edibles, I don't want him to get combustibles. Or you may have somebody who has some other specific things where you think they're going to respond better to a primarily CBD rich, and you might suggest that. The ATC will then still take it from there. But there can be, as it is now, the ability to be able to instruct as sort of a one-way, but there can be some communication back and forth. So it doesn't really change that. But I think you are correct. It does get a little bit close. But the monitoring is really more a matter of just monitoring to see, is this person getting improvement in their craving withdrawal with CBD? If they're not, then he should just decertify them. Because remember, any patient's certification can be revoked at any time for any reason. So with all that in mind, it still isn't prescribing, but we simply wanted to have really rigid guide rails so that it wasn't just certifying goodbye. And in fact, one of the things we're working on is to improve the best practices to try to encourage certifying providers to not just certify and say goodbye. Of course, they have to recertify annually anyway, but we want them to take that more active role of following up, as anybody should when they initiate any type of treatment. Thank you.
Yeah, if I could just follow up.
Yep, go ahead.
Would you believe that I think what you're doing is qualifying who can certify rather than saying rather than really changing the process of certification. So
yes,
in thinking this through a little further, I guess you're really not changing prescribing. One thing though to keep in mind is I believe the omnibus that came from the Senate did change recertification to 3 years.
Yes. Yes, I think that's correct. I forgot about that. Thank you for that correction. But in terms of the qualifying, yes, that was indeed, we were only 6-4 split last year, and the recommendation on this, what made us come to 9-0 was to put these rigid guardrails in. We just didn't want people who were just a PCP to say, okay, here's your certification, go see them, and then there's no follow-up. We wanted somebody who had the knowledge of the most up-to-date information about that interplay of cannabis and opioids, and who would be able to really monitor closely, so that we wanted a part of an active treatment program, not just a general certification. But to do that, the key was very narrowly defined as to who can. Kind of similar to that previous bill for ASD, where we said you needed to see a specialist who deals with ASD for them to say, yep, this is a good thing for this kid, not just a PCP.
I got it. Thanks so much.
Thank you.
Further questions of Representative Knirk? So, Representative Knirk, I note that Representative Marsh filed a minority report. I think he's still available. So maybe I would see if he wants to testify rather than ask you that question.
Fair enough.
Okay, seeing no more questions. Thank you very much. Representative Marsh, do you wish to testify again? Yes, he does.
Thank you, Senator. The reservations that the minority had with this bill in its current form are that the evidence for the usefulness of cannabis and opioid use disorder seems to be somewhat debatable at this point in time, and there may be at least a significant number of cases where it in fact makes opioid use disorder worse rather than better, and therefore I personally would not support that section of this bill at this time. I would support the rest of the bill.
Are there questions of Representative Marsh? I always get concerned when the two Carroll County doctors are not on the same page.
It does happen.
Okay, thank you very much. Griffin.
Yep. Representative Knirk has his hand raised again for a second time, if you'd like me to bring him in.
Yep, go ahead.
if that's okay. Yes, Representative Marsh and I almost always agree on everything, but once in a while we don't. But I do share his concerns. And indeed, as I said, last year when we processed this, we were only a 6-4 recommendation. So we, that's why because we were not as rigid, and we do agree that there are strong concerns. And that's why we very explicitly said that we do not support its use in a widespread fashion, but only as part of a treatment program, so that it is only being done by somebody who really knows. And I would have to point out that 2 of our most skeptical physicians about therapeutic cannabis and opposed it when it first came out, both are people who treat addiction, and they did come along on this. They were not in favor of it back last year when we didn't have these guardrails, but they are at this point, and they're the ones that did the work and the deep dive into the literature. So, I really appreciate Representative Marsh's concerns, and we all shared them, and that's why I wanted to make these really rigid guardrails and keep it with a very minimal use. I would expect there's probably going to be a very small number of people who would ever be able to qualify under these rules. Does that answer your question okay? Oh, sorry, I was not answering your question. I was rebutting. Any questions?
And are there any further questions of Representative Knurk?
Thank you.
Okay, Griffin,
Next I have is Lee Cooper.
good morning.
Good morning. My name is Lee Cooper. I'm the administrator for Sanctuary ATC. Thank you for the opportunity to speak with all this morning. Sanctuary ATC is in favor of House Bill 605. We support adding opioid use disorder to the list of qualifying medical conditions, as this will help expand access to more qualified patients in New Hampshire. We also believe allowing visiting medical cannabis cardholders to have access to New Hampshire ATCs will not only expand access to seasonal residents, but also provide a welcome relief to visiting patients who will no longer have to worry about if or where they will be able to purchase therapeutic cannabis while visiting our beautiful state. Thank you.
Thank you very much. Are there questions of Ms. Cooper? Seeing none. Thank you.
Last person I have signed up wishing to speak is Michael Holt.
Good morning, Mr. Holt.
Good morning, Mr. Chair, members of the committee. Thank you for taking my testimony. For the record, my name is Michael Holt. I am the administrator of the state's therapeutic cannabis program. Representative Knurk stole much of my thunder. I did want to speak and provide information about the second provision permitting visiting qualifying patients access to New Hampshire ATCs. I won't take much of your time, but I do want to make a couple of points. New Hampshire's current law allows limited reciprocity for out-of-state therapeutic cannabis cardholders. The law calls these individuals visiting qualifying patients. The reason we say limited reciprocity is because the law allows patients to possess cannabis in New Hampshire, protecting them from arrest and prosecution if they are compliant with New Hampshire's laws, but it does not permit them to obtain or purchase cannabis in the state. We know that cannabis is federally illegal. We know that crossing state borders with cannabis is an additional violation of federal law. So if New Hampshire allows visiting patients to possess cannabis here in New Hampshire, but affords them no opportunity to purchase cannabis here, then the state law implicitly acknowledges that cannabis will be brought across state lines into New Hampshire in violation of federal law. Reciprocity is also limited under current law in that a visiting patient is afforded those protections only if that person has a qualifying medical condition that is on New Hampshire's list and can produce for a law enforcement officer a doctor's certification of their medical diagnosis. The officer would then presumably compare that document to the list of conditions in New Hampshire law during a traffic stop. So what this bill would do is allow visiting patients to purchase cannabis from any of the New Hampshire ATCs, make explicit that visiting patients cannot purchase or obtain cannabis from a New Hampshire patient or caregiver, clarify and amend the definition of visiting qualifying patient to include our neighbors from Canada who have medical marijuana cards, remove the requirement for visiting patients to show law enforcement officers a copy of their doctor's certification of the medical diagnosis in order to be afforded the state's reciprocity. And lastly, require the department to adopt rules regarding an ATC's verification of a visiting patient's registry ID card prior to dispensing. I'll close my testimony by identifying the need for 2 technical edits to make the visiting qualifying patient provisions of this bill complete. I have sent that draft language for an amendment to you, Senator Bradley, last night. I apologize for the lateness of that. I hope that you'll all consider that amendment at the appropriate time. And I'm happy to take questions.
Thank you very much, Mr. Holt. I'm not sure I've gotten it, so if you could make sure to get it to Kirsten or Griffin, that would be great. Senator Gray.
The question I have is about the visiting patients not having to show that they qualify under one of the New Hampshire conditions. It seems to me that someone who could qualify in Maine or qualify in Massachusetts could go there, get qualified, and then come back to New Hampshire, purchase marijuana, and not have one of the New Hampshire qualifications. Is that true?
Under this proposed bill, this bill would remove the restriction on qualifying conditions for visiting qualifying patients. It does not allow a New Hampshire resident to become qualified in another state and as a New Hampshire citizen. Perhaps I'm misunderstanding your question, Senator, but yeah, you are right. I mean, under current law, somebody with, say, anxiety qualified in Massachusetts for anxiety disorder is not afforded that reciprocity here. Under this bill, they would be allowed that reciprocity here. It removes the burden on law enforcement officers for making those clinical determinations in the field at a traffic stop.
Senator Sherman.
I'm just wondering, Mike, and thank you for testifying today. Following up on Senator Gray's question, we have pharmacists who fill prescriptions. They're not looking at the indication for the prescription. They're looking at whether the person who is prescribing is the correct one. And there's a sort of an assumption that the prescription is appropriate. So I'm wondering, in our case with the therapeutic cannabis, if you have an out-of-state provider certifying and they have an out-of-state card, there's an assumption that that state is appropriately using therapeutic cannabis. So I think that's the leap. It's kind of like off-label use of medications, which is done all the time, and the pharmacists aren't questioning that off-label use. So I'm wondering, is this something that they would even have the ability to know exactly what the reason for the certification in the other state would be based on the card? Do the cards tell you what the certifying diagnosis is?
New Hampshire cards do not include the certifying diagnosis. That would be, that's personal private health information. Sharing that with a law enforcement officer seems odd. In the case of visiting qualifying patients now, there is an education issue where out-of-state patients may not know the state law that limits their reciprocity here. I'm not familiar with patients from other states coming in with certifications. I can tell you that the majority of our patients don't keep a copy of their certification that has their diagnosis on it. They send it to us. I've heard anecdotal evidence from law enforcement officers on this very issue, where even though the law requires them to have a visiting patient produce, in addition to their out-of-state registry ID card, their written certification, their note from the doctor, say that it's virtually unenforceable. I have heard from law enforcement that they will seize cannabis if the patient cannot produce that, and then allow the return of that cannabis, once they can produce it later on. So there's a number of different practical applications of this and complications. What this bill would do, I believe, is simplify this reciprocity for both out-of-state patients and for law enforcement officers who are responsible for enforcing this aspect of the law.
Further questions of Mr. Holt? So, Mike, I just have one on the first section of the bill dealing with the opioid use disorder. Trying to bridge the difference, I guess, between proponents and opponents of it. What if it were to have a sunset, allow it on a temporary basis, see how it works? Administratively, what would your thoughts be on that?
Administratively, I would like that question to be brought back to the board. That was not considered by the Therapeutic Cannabis Medical Oversight Board. I agree with Representative Knirk in that this is expected to be used very seldom. The number of providers in the state who are certified in those specialties is low. We have identified the certification entities that do certify in these two specialties. We can look them up. We can easily administer verification of those board certifications when these certifications come into the therapeutic cannabis program. Administratively, I don't think a sunset is necessary. The board, the Therapeutic Cannabis Medical Oversight Board, also has the responsibility not only of considering additional new conditions, they also have the charge to look at existing conditions. So within their current scope of authority, they could take this up again, review evidence, its implementation, and make a further recommendation to remove it. Forcing them to do that work based on a sunset provision is mandated extra work for them, at some point.
Okay.
So how's that?
Yeah, thank you. Further questions of Mr. Holt? Okay. How are we doing, Griffin?
Last person I have signed up wishing to speak is Keenan Bloom. I think
Okay.
this is him.
Senator Gray, can you take over for a couple of minutes?
Yes, sir.
Thanks.
Keenan, you should be able to unmute on your end.
All right. Thank you very much. And thank you, senators, for your time. My name is Keenan Blum. I'm here representing Prime ATC. Most of the points that I wanted to make were very well made by the previous speakers, by Mike Holt and Jerry. I just wanted to say that we are in support both of opioid use disorder being added, which, as it was said, would be minimal. We have seen great results, though anecdotal, with using cannabis for opioid use disorder. Additionally, we do have a number of patients that do not reside in New Hampshire year-round, and this would be very valuable to them to be able to not have to choose a particular state with which they are covered and able to be dispensed therapeutic cannabis. Those that spend half the year in each place really do end up in a bind when they travel to the other location and to the other state for the rest of the year. So that is really all I have to add that is unique. I appreciate everyone's time. If anyone has any questions, I'm happy to answer them. Thank you.
Questions from committee members? All right, seeing none, thank you very much.
Thank you.
Griffin, do we have anyone else?
There we go. Sorry. Yep, I got it now. I don't have anybody else signed up wishing to speak. However, I do have a Grant Ellis with his hand raised.
Mr. Ellis.
Mr. Ellis, you should be allowed to speak.
Good morning, Senator. Can you hear me?
Yes.
Thank you, and good morning to the committee. I am an out-of-state medical cannabis patient, and I appreciate the committee's consideration of the bill this morning. My name's Grant Ellis. I'm a disabled medical cannabis patient from Massachusetts who has family in New Hampshire. I'm the president of the Massachusetts Cannabis Reform Coalition as well. So I've spent some time this morning listening to your discussion of HB 605, and I thought it was well informed. I support the bill in its entirety. Unfortunately, I don't have as much to add on the opioid use disorder question. I think your consideration of it is informed, well-intentioned, and I'm sure a compromise will be reached. I do, however, want to weigh in strongly in support of the provision allowing out-of-state patients like myself to not only possess our medical cannabis in New Hampshire, but actually obtain our medical cannabis in New Hampshire, and hopefully, if another bill passes, grow our medical cannabis in New Hampshire for extended periods of time. I'm homebound and disabled myself, and the last time I went to New Hampshire, I didn't want to bring any of my cannabis medication across the border. I ended up for a month and a half having to go back on a dose of opiate medication that I had not been on for 5 years for my trigeminal neuralgia due to not having cannabis while I was visiting family in New Hampshire. So this bill would make a difference in my life. It would make a difference in the lives of many patients, and I do hope that you will vote ought to pass. And I also wanted to clarify one discussion that was happening earlier about if this would apply to a New Hampshire resident going out of state and then getting a medical card and coming back. I don't believe a New Hampshire resident would qualify under the definition of visiting qualifying patient. So I don't believe that would apply in this situation. And thank you for your time.
Questions from the committee? I have a question. If a college student were here in New Hampshire, had a condition that was approved in their state but not here in New Hampshire, wouldn't that circumvent New Hampshire law?
Only for the first 90 days, not for the first 90 days, but on the 91st day, yes, because I believe the bill defines visiting qualifying patient as someone who is in New Hampshire for 90 days or less. I'm not positive.
Okay, thank you. Any other questions from committee members? Griffin, do we have any other hands?
I do not see any other hands raised wishing to testify on this bill. If there are any, please raise them now or press star 9 if you're on the phone. And I do not see any other hands, Senator.
And since Senator Bradley is back, I'll let him close the public hearing should he choose to do so.
Thank you very much, James. Okay, seeing that we have no other testimony on House Bill 605, we will close the public hearing and open the public hearing on House Bill 157 and recognize the sponsor, Representative Edwards. Good morning.
I'm afraid, oh, yep, there he is. Representative Edwards.
Yeah, hello. I'm sitting here waiting for HB 381, I believe. Is that what you just opened, sir?
No, I opened your other bill, House Bill 157, relative to the State Health Improvement Plan.
Okay. So, I pardon me for being taken off guard by this.
No worries.
I can talk to you about it, but it's not going to be particularly formal. I'm Representative Jess Edwards from Auburn. I initially introduced a bill that would have, and Dr. Tom Sherman, Senator Sherman can help me out along the way, I believe. My original bill intended to terminate the SHAWSHIP efforts, and we sent it to HHS, and it was reviewed, and the chair and vice chair thought it would be a better idea to amend it. And so we convened under the chairman's direction a small task force composed of Senator Sherman, Representative Marsh, Representative Pearson, myself, Mr. John Williams, Ms. Patricia Tilley, and there may have been some others. But what we instead ended up doing with the amendment is we decided to add a couple of new positions to the commission. And those positions would include somebody from the Josiah Bartlett Institute to represent kind of the free market aspect of thinking about health policy. And we also brought in somebody, I think, from BIA, again, to represent sort of the economic interests of the whole state as the commission looks at improving the well-being of New Hampshire residents. We went through the language also and cleaned some of it up just so that there would be more precision. I think that was more just editorial flourishes and improvements rather than anything substantive. Once we ended the task force, it seemed like everyone was aligned. Senator Sherman, I'm happy to have you speak up, sir. But it seemed like we were all aligned. The HHSEA looked at the amendment, and I believe they approved it unanimously because of the success of the task force. And now it's with you. And so it would be my hope that you would approve 157 as amended. And with that, I'll take questions.
Okay, and I would just note that the House passed the bill out of committee 20-0, and it was placed on your consent calendar. So
Yes, sir.
Are there questions of Representative Edwards? Senator Sherman.
I'm just offering to speak, or if Representative Marsh is still there, he could speak, but whatever you'd like me to do.
Go ahead. We'll recognize Senator Sherman to speak.
Yeah, so I really want to thank Representative Edwards for being willing to work with us. It was a great task force. It made SHASHIP better. It also rounded out bringing in, I'm trying to remember which group came in. I think it was Josiah Bartlett joined the SHASHIP to provide a balancing perspective. And it also brought on the members that HHS had needed added. So it met all the needs of HHS. It added areas that we will look at on SHASHIP, which is State Health Assessment, State Health Improvement Plan, and it rounded out the membership to increase the balance in the membership. So I'm happy to take any questions, but it is meeting pretty much everyone's needs at this point. I think it addressed the original concerns of the sponsor. And I appreciate his willingness to work with Representative Marsh and me and others, especially the department, to make sure that everyone's needs were met with this bill as amended.
Great. Questions of Senator Sherman? Okay, seeing none. Griffin?
Next I have is Representative Marsh.
Okay. Good morning again, Bill.
Good morning again, Senators, and I'm pleased to discuss with you the committee amendment to House Bill 157. As Representative Edwards said, House Bill 157 began as a repeal bill. It became clear that important stakeholders felt disenfranchised by the process developing the SHASHIP, and we were happy to address that issue. And we specifically wanted to thank Senator Sherman for his role in orchestrating the meeting that he addressed, because we did not have the staff to do that. The amendment instead revised the charge to the council and added members to the council such that the previously disenfranchised stakeholders felt that their concerns had been addressed. I did give you line numbers in my written testimony, and I will tell you that those are the line numbers from 0488H, as the PDF on the general court site lacked line numbers. I will disagree with Representative Edwards, as I believe we did make some substantive changes to the charge. Highlights include an increased scrutiny on access to critical services, including maternity. And I think it's becoming more evident to everybody that we need to pay attention to maternity in the state of New Hampshire. We paid attention to the cost of healthcare and health insurance. We paid attention to fiscal stability and sustainability. We wanted to make sure that access was sufficient and equitable and not just equitable. And we put an increased emphasis on public health. A new goal is to plan on ways to reduce the cost of healthcare both to individuals and to the system overall, recognizing that those two items are not always the same. The work product is to be a resource for centralized and decentralized decision-making, recognizing that many key decisions get made not by government, but by the various hospitals and service providers across the state. The council's recommendations are to include both costs and benefits. And as you said, Senator Bradley, the bill passed HHS and Elderly Affairs 20-0 and passed the House on consent. I thank you, and I'll be glad to take questions.
Are there questions of Representative Marsh? Seeing none. Thank you again.
Thank you.
Next person I have signed up to speak was Representative Jerry Knurk.
Thank you very much. Can you hear me okay?
Yep, we're good.
All right.
Go ahead.
I did not give you any written testimony in this because this is going to be short. Again, I'm Representative Jerry Knurk, representing Carroll County 3. I also serve as the vice chair of SHA-SHIP. And to remember, the goal of SHA-SHIP is to improve the overall health and wellness of the citizens of New Hampshire, to improve the quality and experience of care, to reduce costs to both individuals and the healthcare system, reduce inequities, and optimize the public health and healthcare deliveries. And the data, as Representative Marsh pointed out, is not just for the use of the state. Nonprofit entities, hospitals, healthcare systems, providers, insurers will all be able to make use of the data to determine how to improve that delivery of healthcare to make it more cost effective and thereby decrease costs and increase quality. It does expand the membership, which is already large, but this large membership lends a diversity of opinions, and we've increased the diversity with Representative Marsh's amendment, Marsh and Sherman and others, amendment allowing the development of a much better program. It expands the membership. It does clarify the charge and adds things that should have been in there in the beginning. So the bill, which I certainly opposed when it came, is a bill which I strongly supported once we amended it out of our committee. And so I urge passage of HB 157. Thank you very much.
Are there questions of Representative Knurk? Seeing none. Thank you very much.
Next I have signed up is Patricia Tilley from DHHS.
Good morning, Ms. Tilley. How are you?
Good morning. Good morning, Chair and members of the committee. Again, my name's Patricia Tilley, and I am the Deputy Director of the Division of Public Health, and I'm here on behalf of the department to support HB 157 as amended for the State Health Assessment, State Health Improvement Plan. As you've heard, we call those the SHA and the SHIP. Representatives Edwards, Marsh, and Knurk, and Senator Sherman have done my work for me today. As noted, the amendment adds new membership, ensuring representation across sectors, and provides more robust language in assessing and identifying gaps within the healthcare service delivery system. In the House, as you heard, we work very closely with the sponsor and Senator Sherman and Representative Marsh and others to answer questions, ensure that membership and the focus of the SHA and the SHIP Council were clearer. We agree with Senator Sherman's and Representative Edwards and others today that the additions made the council better, sharpened the focus, and really had us zero in on access to care and the impact of costs. So I think that's been a great summary. Thank you. And I don't want to take any more of your time, but I'm always happy to take questions.
Thank you very much, Ms. Tilley. Questions? Seeing none. Thanks so much.
Thank you.
Next I have signed up is Edward, and I hope I'm saying it right, Shinshala.
Good morning, sir.
Thank you, Senator Bradley. And Griffin, you did an exceptional job at pronouncing my name. It took me a few years to get it right growing up. So I appreciate all the work you've put into the legislation on the Shawship. I am on the commission and enjoy the opportunity to see how we can improve the health and wellness of the people we serve in our communities. And I want to echo Representative Knirk's interest in having the data available above and beyond policymakers. I think to have the BIA engaged in the health and wellness is an interesting construct that I think that they would benefit from, especially the small businesses in the North Country predicated on tourism. Some of the shops have few people, and the healthier they are, then the more than they can serve the tourists when they come in, and it drives the economy, which I think is important. So I look forward to continuing on the commission and working with some new colleagues. I think we'll bring some interesting new perspectives that in the past, sometimes we've had a hard time getting access to their voices. So that's my, I did provide written testimony for your consideration, and thank you for your time. And if there's any questions, I'm more than willing to field them. So other than that, have a great day. Be safe out there.
Thank you very much, sir. Are there any questions? Seeing none. Thank you very much. Griffin.
I got, I'm just going to say Joe.
Good morning, Miss Ashheim.
Good morning. I will be brief as well, as much has been stated, but I am representing the New Hampshire Public Health Association today, an advocacy organization to improve the health of people in New Hampshire. I just wanted to make 2 points that have not been addressed. So I served in Trish's position actually previously, and also in a similar position in New Hampshire. And so I've helped develop 2 state health assessments and plans. I just wanted to make the point that they are used, they do not sit on the shelf, and they really help to focus resources on the needs of the most important needs of the people. The other point I wanted to make is that I think this amendment does strengthen the bill because conducting a state health assessment and plan is a national standard for health departments. And that standard speaks to broad engagement of partners across different disciplines and organizations. So I think that the bill as amended strengthens what we had previously. So in sum, the New Hampshire Public Health Association supports the amended bill, and I thank you for your time.
Thank you very much, ma'am. Are there any questions? Seeing none. Thank you.
Senator, I don't have anybody else signed up wishing to speak on House Bill 157. If there's anybody else who'd like to testify, please raise your hand or press star 9. I'm not seeing anybody, Senator. Oh,
okay.
I'm sorry, Senator. I got a Heather who raised her hand.
All right, yes, I apologize. I'm joining a few minutes late. I just need to double check on which bill we are discussing.
We are discussing, I lost it here.
House Bill
157 that deals with the state health improvement plan.
All right, well, thank you for that. I appreciate it. And that was not the bill I was looking for.
Okay.
I had a little bit of trouble finding the Zoom link, so.
No worries. You're probably waiting on 381, so we'll get to that shortly.
I was actually waiting on 605.
Oh, well,
Missed it.
Okay.
Heather, you can always email. My email's on the website under the Health and Human Services. If you have any testimony you want to submit to the senators, you can always email it to me and I will share it with them.
All right, absolutely wonderful. I appreciate that. Sorry for disturbing you.
No worries. Thank you. If you,
let's see, I don't have anybody else wishing to speak on this at this time, Senator.
Okay. All right. I'm going to close the hearing on House Bill 157, and we will go into our last hearing of the day, House Bill 381. I just want to note Senator Avard, Senator Sherman, and myself all have prime bills coming up. So I think this hearing is going to go a few minutes more than some of the others. I would hope to be able to exec the following bills before we're done today: 378, 479, 157, and 582. So just stay flexible, and after our primes, we'll try to come back and pay attention to your email and text, committee members. So with that, I want to recognize the sponsor of House Bill 381. Again, Representative Edwards. Good morning again.
Thank you, Senator. Again, this is Representative Jess Edwards. I represent Auburn, Chester, and Sandown here today to introduce House Bill 381 relative to laboratory testing. What this bill is intended to do is to create flexibility in our diagnostic healthcare segment of our system. It would allow individuals to go and order their own laboratory testing. Laboratory testing is non-invasive in the sense that it's not going to cause anyone harm in order to go get a laboratory test taken. They can order that on their own without having a provider. This helps in those instances where a person may be in between physicians, in between health insurance, and knows that they have a chronic condition for which they should get their laboratory results periodically. To me, this is personal. I found myself in a situation where I was before the VA medical system kicked in, and after I left my job, I didn't have health insurance. I needed A1Cs, and I was refused an A1C, saying that I needed to have a healthcare provider order it. So I was in a catch-22 where I didn't yet have a healthcare provider and I didn't have insurance, but I knew I needed an A1C. An A1C is a pretty simple thing to read after you've had a few of them and talk to your physician a bit. So I thought I was perfectly competent to do that, but I was precluded. So this bill would, had it been in effect, it would have allowed me to ask for the lab test. It would have allowed the laboratory to refuse still. They're not required to provide the test. It would require me to pay for it, so I couldn't slip the bill over to my insurance company if I had one. This is a personal obligation to pay for this. And because your provider may never know that you had this test done, there's a liability waiver in there for a provider who just is unaware that the lab test even exists. So it's meant to create flexibility. It's meant to improve bodily autonomy. And as a Representative Marsh had pointed out in some House testimony, we have 40 labs currently in New Hampshire that will do this testing, but because they aren't authorized, they end up shipping the lab tests out of state for them to be, the tests to be run, and then the results come back. And so what this would allow is, in terms of a change, is it would allow that testing to actually take place in the state. It's incrementally a small amount of additional business for our own New Hampshire providers. And it would just probably cause other labs to relax a little bit in terms of allowing an individual to come in and order their own test. So I think this is a good bill. And I believe the HHS committee in the House approved it something along the lines of the 16-5, something along those lines. And I don't actually recall how it passed the House. Probably passed on consent or something, I guess. But Representative Marsh and Knirk would know that better than I do right now. So this is a medical freedom bill, and I'm proud to have sponsored it and to have had the help of the committee throughout the process. I'll take questions if you have any, sir.
Questions of Representative Edwards? Seeing none.
Thank you.
Thank you.
Next person I have signed up, Senator, is Representative Jerry Knirk.
Okey doke, thanks.
Okay, thank you very much. Y'all can hear me okay?
Yes.
Okay. So though I do agree that patients should be empowered in managing their health care, I think that allowing patient-ordered blood testing is not a good idea. I should also, oh, by the way, I'm sorry, for the record, Representative Jerry Knirk, Carroll County District 3, but I'm also a retired physician. Results of laboratory tests really they must be interpreted in the context of a patient's history and physical. Contrary to what many think, diagnosis of a condition is primarily based on the history and physical examination. Usually, by the time you finish those two, you're 95% of the way there. The results of lab and imaging studies primarily serve the purpose of confirmation of or ruling out of a working diagnosis. Even when lab tests are used as screening tools, considerable interpretation of the results is needed in the context of that patient's history and physicals. Now, important things to understand about lab tests. They're often not dichotomous with just a yes or a no value. There are ranges to be considered. The range of normal is the statistical range with standard deviations. They're designs that if out of 20 tests, one will be guaranteed to be abnormal in a normal person, because that's how you do basically the 5% tolerance. Many tests also have significant false positive or false negative rates, requiring confirmation with the history and physical exam or with further testing. False negatives are not a flaw of the test, but they must be understood by the ordering person. And the results of many tests, especially serologic tests, are highly dependent upon the phase of the illness. This is exemplified most clearly by the difficulties understanding blood tests in Lyme disease. If the Lyme test is done before the antibodies develop, the test can be falsely negative even in the face of a clear infection, which may be obvious on the history and physical, but not confirmed by the blood test. And the antibodies will persist even after the Lyme disease has been successfully treated with antibiotics, leading to a later false positive result. Even providers have difficulties with these concepts. Now, they're in the literature, routine blood tests for young, healthy patients are not recommended by evidence-based guidelines. Frequent false positive results lead to anxiety and lead to a diagnostic cascade of further testing, which is needed to deal with the first result, which is often costly and may expose the patient to unnecessary risk. The Institute of Medicine, in a 2010 report, estimated that unnecessary testing added $210 billion to healthcare spending in the US each year. And they're talking about unnecessary testing by providers, let alone if we open it up to non-providers to order their own. The issue about the impact upon the patient goes just beyond anxiety. A patient may get a result that leads them to believe they have a disease which they do not have, leading to an increased sense of poor health and changes in their behavior due to this misdiagnosis. The time that the provider spends counseling the patient about the results of unnecessary tests would be much better spent providing proper care. Outside costs and wasted time, besides outside costs and wasted time, there's the patient's altered perception of their state of health. So many years ago, I'm a retired orthopedic spine specialist. Many years ago, I saw a woman who was in her 20s who for a couple of years had altered her lifestyle, cut down on activities, and considered herself disabled on the basis of a positive rheumatoid factor blood test. because she thought she had rheumatoid arthritis. But it's important to understand that the rheumatoid factor blood test has a 30% false positive rate. When I confronted her with the fact that nothing in her history or her physical supported that diagnosis, she then confided that the rheumatologist she had just seen in the previous month also disagreed with that diagnosis. She had lost a significant part of her life to a misdiagnosis based on a blood test alone. Again, in my field in spine, we have very strong evidence that informing a person that their spine MRI scan shows degenerative changes, which is an absolutely normal finding in humans as they age, like getting wrinkles and gray hair, even in the absence of any spine disease or symptoms, we see these changes. But just simply telling that to the person will lead them to perceive a poorer state of health and leads to alterations in their behavior, which can be negative and actually deleterious to their general health. The sponsor has made the argument that this bill will allow diabetics to follow the hemoglobin A1C measure. That's a measure of long-term control of blood sugar. But there's a lot more to managing a diabetic than just following one blood value. And many physicians are comfortable ordering a lab to be done 6 months later without needing an office visit for an established patient that they know well and can trust, and then we'll do a phone follow-up. In addition, for that person who doesn't happen to have insurance, you just go to the internet and there are home kits that you can order that are available for testing your hemoglobin A1C. The argument has been made, and the sponsor just made it, that the blood is currently being drawn by in-state labs to be sent out-of-state labs for testing. So we should just allow it in order to keep that business in New Hampshire. Well, that reminds me, it's a little like giving permission for bad behavior. When your teenage kid comes in and says they want to smoke because, the other kids are doing it. Well, we don't say, okay, well, I guess you might as well because the other kids are doing it. We do not endorse a practice which is bad. And we should not endorse a practice which is bad medical practice just because some other states are doing it. Lastly, regardless of the language in the bill, the provider has a duty to deal with any abnormal result of which they become aware. And I think it'd be difficult for this to stand up in a court of malpractice, but more importantly, the Board of Registration in Medicine develops duties or standards of practice and expectations. The provider has to deal with an abnormal result if they become aware of it, even if they didn't order the test. So that exemption won't matter. Under this bill, lab tests will routinely make it into the electronic health record, where they will not be flagged to be seen by the provider, but the provider may eventually notice its presence and they better act upon it if it's abnormal. In closing, the combination of Dr. Google and patient-ordered blood testing will not cut healthcare costs and may probably in fact increase them, and will likely lead to increased misdiagnoses and poorer health. I voted against this bill in committee. I voted against it on the House, and I think it should be ITL. Thank you, and I'd be glad to take any questions.
Are there questions of Representative Knirk? So, Representative, I have one.
Sure.
Are there any circumstances or a limited number of tests that are easily administered and determined by, the patient, him or herself, that this could apply to, but not more complicated testing?
Actually, that is an excellent question, and the idea that Representative Edwards brought up is exactly the best setting. Diabetics who have taken care of themselves for a long time really know what they're doing. And we were always trained as residents. When you have a patient comes in who has diabetes and they tell you something, listen to them, because they've been living it for a lot of years. We trust them to manage their blood sugar with doing their own blood sugar measurements. And I would think that is the one setting where they might be able to manage and look and notice that their hemoglobin A1C is off. Though if they've been routinely managing their blood sugar tightly and their hemoglobin A1C, is out of whack, that might bring up a question as to why, and they probably ought to see their provider at that point. In any case, long-term maintenance, such as in diabetes, that could be a reasonable option. Most other ones probably require a higher level of expertise. For example, you might say, Well, a guy over 50 might monitor his PSA, prostate-specific antigen. But that's also an area where there's a great deal of uncertainty about what the implications are and when you should make a move, and probably is not wise to be making those decisions on your own. I should also note Dr. Gilbert Welch from Dartmouth has been our local authority on the overuse of testing, both diagnostic imaging and also blood, in terms of the harms that they cause by leading to these diagnostic cascades. So conceivably, and a few of us did bring up the idea of narrowing this in a, in a retained bill, trying to bring it down to just a couple of maintenance tests for that occasional person who simply doesn't have insurance. But again, if a person's a well-established patient and they have insurance, their primary provider is probably perfectly happy to put in the order for 6 months from now from get hemoglobin A1C and then check in by phone. Don't even have to see each other. That's pretty routinely done. So it's a very small, I have to confess, we do have the problem that our healthcare system leaves some people uncovered, but figuring that out for another day. But in the meantime, this is a kind of mediocre Band-Aid. And as I said, hemoglobin A1C, you can get the little device on the internet, test it yourself if you wish to do so.
Okay. Further questions of Representative Knurk? Seeing none. Thank you.
Thank you.
So next one I had is Representative Marsh.
Thank you, Senators. Can you hear me?
Yep.
Very good. For the record, I'm Representative William Marsh again, and I am in support of House Bill 381. So this is another one of those instances, Senator Bradley, where Dr. Marsh and Dr. Knurk disagree. Simply, this bill allows patients to order laboratory tests at their own expense without a doctor's orders. The bill's opponents paint this bill as dangerous to patients because patients may not know how to interpret the tests they may order at their own expense. They also claim this will drive up healthcare costs due to follow-up testing required. However, today in New Hampshire, there are between LabCorp and Quest approximately 40 testing centers across the state where patients can, under existing law, get their tests done without a physician's order. These tests are sent out of state for processing. We did not hear any data that these sites have caused any problem due to patients being unable to interpret their results. Neither have we seen any evidence that follow-up testing from their tests have driven up healthcare costs. What House Bill 381 does is to allow New Hampshire labs to compete with these out-of-state labs and offer the same testing. It specifically provides that insurers do not have to pay for the testing done in this manner. The legislation is modeled after a similar working program in Arizona. Existing law puts our New Hampshire labs at a competitive disadvantage. This bill simply eliminates that disadvantage. We all know sometimes patients want particular tests, but their doctors do not agree. Allowing patients to perform those tests at their own expense may well result in a more amicable resolution than having them confront their physicians. We all know many patients have health insurance with high deductibles and high copays. Allowing them to get routine testing done without having to see a physician first may well enable them to obtain needed health care at lower cost. And to answer the docket question, the bill passed HHS and Elderly Affairs 14-7 and the House 264-89. I thank you. I'll be glad to take questions.
Questions of Representative Marsh. Senator Whitley.
Thank you, Mr. Chair, and thank you, Dr. Marsh, for taking my question and for all your testimony today. It's been a busy day for you and Representative Knurk. So I'm curious, you had shared some information about those companies that are already doing that sort of direct testing or allowing patients to do the direct, requesting direct testing. So I'm wondering if you can share a little bit more about how those companies are, authorized to do that in New Hampshire, how this bill would sort of change that current practice, and what are the kind of tests that those existing companies are doing in New Hampshire?
I believe they're using the Interstate Commerce Clause to perform their testing, so it really is not relevant to what our state law is, and I don't believe that this bill would change their practice in any way.
Follow up?
Mm-hmm.
And the last question was about what types of tests are they currently conducting? Those directly requested by patients.
I can't answer that question with specific information. I'm sorry. I believe Representative Merchant could, but I don't believe he's on the call.
Thank you.
Further questions? So Representative Marsh, maybe answer the question I asked Representative Knirk. Are there some, more limited circumstances that this bill could go forward without it being quite as wide open as we find it now?
One of the things I learned in my years of clinical practice is that patients know their own bodies pretty well. And even with some relatively rare diseases, patients may know their own conditions really quite well. And my opinion as a physician is that doctors decide to not listen to their patients at their own peril. So I think that it would be exceedingly difficult to limit this to just specific conditions, because the patients who have the other conditions may be very familiar with the conditions that they actually have. And so I really can't see any practical way of doing what you suggest.
Okay. Any further questions? Seeing none. Griffin.
Yep, so I'll bring in Dr. Gary Sobelson. I do have two Gary Sobelsons in the attendees list, so we'll spin the wheel. Here we go. Let's try that one.
Is that working, Griffin?
Yep, can you hear us?
I can hear you, thank you. Thank you, Senator Bradley and members of the Senate Committee. My name is Dr. Gary Sobelson. I'm getting to spend Wednesday mornings with you on a regular basis, I believe. But I've been a family physician in Concord for the past 37 years, and I'm here representing the New Hampshire Medical Society in opposition to the passage of HB 381, allowing any person to order any laboratory test on a direct access basis. I'll try not to be overly redundant, and I'll try to be quick. HB 381 tries to pass the responsibility of ordering, consultation, and interpretation of lab tests from trained, educated, licensed clinicians to individuals. And despite language that tries to change the physician-patient relationship, to change liability rules, medical practice and ethics are not simply changed by legislation of this nature. While some entrepreneurs in some states are doing this as described, this bill extends an essential practice of the science and practice of medicine to the general public. Medical practice is complicated, and that's exemplified by the prolonged training endured by clinicians and our strict licensing process. Frankly, laboratory medicine, including test ordering and interpretation, is probably among the most complex aspects of medical practice. And efforts like HB 381 that broadly shift this to a consumer-driven model is therefore likely ill-advised and possibly dangerous. Will patients, as described, use this opportunity as an excuse to avoid proper medical care? Is knowing your HbA1c, as Dr. Knirk mentioned, enough to manage your diabetes? Will self-diagnosis lead to unnecessary increased downstream medical procedures and costs? This is demonstrated in the medical literature, and it's exemplified in our state, notwithstanding the comments of my colleague, Dr. Marsh. There's a company in the state that's been around a long time called Lifeline. And you can go into a school or a senior center and get all kinds of fancy, unrecommended tests ordered and performed by you, then brought to your doctors, who are then frankly, have an ethical and clinical responsibility to follow up on them. And expert groups have decried this practice for decades. Again, it doesn't mean that entrepreneurial efforts haven't continued, but we have already examples of the problems with this. The FDA has a process to access and license medical testing designated for non-professionals, and they use a rigorous scientific process to do that. That's how we have home blood sugar testing. That's how we have home pregnancy tests and ovulation tests. And most recently, we have some approved home COVID tests. And when they make those determinations, they look at accuracy, the meaningfulness, the cost, and very importantly, the risks and benefits of such approvals. The responsibility for ordering most laboratory tests is a prime responsibility of the practice of medicine. And while anticipating Senator Bradley's question, the Medical Society absolutely agrees that certain specific tests that are simple and comprehensible to non-clinicians, and by the way, a lot of these are in the FDA pipeline, maybe cholesterol testing, maybe such A1C testing. These are good ideas, and they frankly can and should come to be. Opening up the broad array of tests, metabolic testing, organ function testing, immunologic testing, would be a danger to New Hampshire citizens, and we ask that you oppose HB 381. Thank you.
Are there questions of Dr. Sobelson? Senator Gray.
Yeah, the concern that I have is that if a person is being influenced by someone else, then that person could be providing medical care or medical treatment, and this bill facilitates that. I'd like to get you to comment on that, Doctor.
Well, I think what you say is true. This is the complexity of medical care. You know, there are many reasons why people are concerned about their health and want to have diagnoses made and proper treatment made. Whether it's a lot of times those influence of other people are good, Senator Gray. So I'm actually, I can see both sides of that. I'm not exactly sure if that's would be an advocacy for increased testing or less. What I appreciate it when family members, when spouses, when friends encourage my patients to get proper care. The key element there is proper care. And I would argue that seeing a licensed clinician in New Hampshire affords you excellent proper care. It has been identified that there are people who don't have access, and this is where the problem comes up. But the danger here, the Pandora's box of opening up your ability to self-test, is we haven't addressed the issue of your access. What we've done is increase the data available to you, which while I would agree with Representative Edwards, a responsible diabetic should be able to follow their A1C, and frankly, they can already. But I would say that perhaps the Dr. Marsh, who's an ophthalmologist, that perhaps someone who's used to treating their regular allergies with ophthalmologic steroid drops, I doubt that he in practice would say, well, gee, we should just make those readily available because trust the patient. They know what they have. Because he would understand the dangers of those treatments. Now, that's not diagnostic, that's a treatment. So it's a long answer to your question, but it's to say that there's both good and bad in that, Senator Gray.
Well,
go ahead, Senator.
I guess I go a little further than that. I go that someone could be practicing medicine without a license, and it would be much harder to prosecute them based on them being able to have the patient go in and order tests, etc. That's where I was kind of going with that question.
I think that is as part of the essence of my testimony, that in the view of the New Hampshire Medical Society, the broad array of laboratory testing is the practice of medicine. It's as much the practice of medicine as prescribing prescription drugs. It's probably just as important. It may be more important. And therefore, I would agree with you entirely that we should be very careful about opening up the practice of medicine to the general public, which is not to say that there aren't aspects of that the public with adequate information and adequate safety can do on their own.
Thank you.
Further questions of Dr. Sobelson? Seeing none.
Next person I have signed up to speak is Dr. Michelle Hoff.
Good morning, Doctor.
Good morning. Hi, Senators. Mr. Chair, thank you so much for the opportunity to speak. My name is Dr. Michelle Haas. I am here today on behalf of the New Hampshire Association of Naturopathic Doctors. Our organization represents about 150 New Hampshire licensed naturopathic doctors. We are respectfully requesting that item 1 of this bill, which lists types of licensed medical practitioners, be amended to include naturopathic doctors. And the reason for that is that as it's currently proposed, HB 381 is actually in direct conflict with our Practice Act, the Naturopathic Healthcare Practice Law passed in 1995. This is RSA 328E. And that allows for naturopathic doctors licensed in New Hampshire to order and interpret labs. We have a further concern that in item 3, it says that if a provider who is not considered a licensed medical practitioner, as defined in item 1, orders labs, they would have to write in big bold on the lab that it's the responsibility of the person who is tested to arrange with a licensed medical practitioner for consultation and interpretation of the results. Well, as naturopathic doctors, we order a lot of labs. We are licensed medical practitioners who can order and interpret labs. So this would be circular. We do support this bill as an organization, assuming we are included in it. As Representative Marsh pointed out, self-ordering labs has been going on for quite a while, 10, 15 years. I don't think that that there will suddenly be people doing this who weren't before because they see this bill as permissiveness. We actually support that item 3 would encourage a referral from a non-licensed medical practitioner to a licensed medical practitioner for proper interpretation. I see this all the time, honestly. I had a situation the other day where a nutritionist ordered a lab and had no idea what to do with the result. It was the wrong test to run. It created a lot of anxiety in the patient. And so I ordered the proper lab for her. And, I would rather that scenario than people who are out of financial desperation, ordering their own labs, interpreting their own labs, treating themselves. I would much rather that they get the proper interpretation and care for those situations. So we do support it, assuming we're included in it. And I'm happy to take any questions anyone might have.
Are there questions from the committee members? Seeing none, thank you very much. And Griffin?
Next up, I have Marissa Chase.
Welcome, Ms. Chase.
Good morning, Senators. How are you?
Fine.
Thank you so much for allowing me to testify today. My name is Marissa Chase. I'm the Executive Director for the New Hampshire Association for Justice, which is a statewide professional association of trial attorneys. I had sent you written testimony on behalf of Nick Abramson, a medical malpractice attorney at the firm of Abramson, Brown and Dugan in Manchester. I won't reiterate the comments that have already been made or repeat the written testimony I submitted to you. But one thing I just wanted to kind of drive home as to the liability aspect of this. In paragraphs 3 and 4 of House Bill 381, the language is internally inconsistent and contradictory. It requires consultation with a medical provider, but then tries to take any duty of care away from that medical provider, which it's not really based on the duty of care in the medical sense is not based on a legal concept or a statutory construct. There is no statute that spells out the medical duty of care. So in medical malpractice cases, as opposed to any other kind of civil litigation, the standard of care is higher and it's based upon medical concepts. These cases are much more complex and actually require a medical expert witness in order to prove the standard of care. It's not a general legal concept based on reasonableness, as I'm sure you've heard me talk about ad nauseum. It's based on what a reasonable medical provider would do in the same or similar circumstance. So I just want to kind of, make the point that this bill seeks to have a simple fix to many, many complicated legal and medical issues. And just on a personal note, I dropped a propane tank on my toe a few weekends ago, and I had to go and get my husband had to drive me to go and get a x-ray. When I saw the x-ray, I thought, great, I'm in the clear. This looks great to me. And then they came back and told me, oh no, your toe is broken and these are the different boots you have to wear. I know that's not what the kind of laboratory testing that the bill seeks to allow any individual to pursue, but whereas the language is so broad, I think if I didn't have to embarrass myself and tell a medical provider that I dropped a propane tank on me and could and think that I would be able to order such a test on my own and save myself that embarrassment that I'm sharing with you all here today, I might be inclined to pursue that route instead. So just to reiterate, NHAJ is opposed to this. If the inclination of the committee is to ITL, I think that would be preferred. If the inclination of the committee is to interim study and try to pursue a narrower set of lab tests, such as Representative Edwards was talking about, we'd be more than happy to participate in those conversations.
Questions from committee members? Seeing none, thank you very much. Griffin?
Thank you.
Marissa was the last person signed up to speak on this bill, House Bill 381. Oh, I do have Paula Mattis from, it appears, the Department of Corrections.
Ms. Mattis.
Good morning. Thank you for allowing me to provide some very brief testimony. I am Paula Mattis. I am the Director of Medical and Forensic Services for the New Hampshire Department of Corrections. We submitted testimony when this was before the House Committee regarding the language. It states that, I'm sorry, I don't have the line, but in section 2, that offers tests to the public on a direct access basis. And in my original testimony, I suggested different language for direct access. In retrospect, we still have concerns because of we're not sure what direct access means. Public may exclude those who are incarcerated, residents of our system. But for many of the reasons described by those previously, we are concerned about that particular language. So I'm requesting that perhaps instead of working with whatever direct access may mean, to put wording in to the effect that excluding the incarcerated population or something along that lines. Again, there are many reasons, as stated previously, with regard to cost, with regard to
Get out of here.
Yeah. With regard to cost, with regard to where these tests may be coming from. And in addition, our population could potentially bring us to court with regard to getting them to these laboratory testing sites, which could create a real problem for our system. That's it. And I will submit written testimony to Kirsten. And if there are any questions, I'm happy to answer them. If not, thank you for your time.
Questions from committee members? Seeing none, thank you very much, Ms. Mattis. Any other hands, Griffin?
I do see Representative Knurk wishing to speak a second time.
All right, Representative Knurk.
Super fast. I think it's important to note that both in the House and in the Senate hearings, no representatives of any of the labs came to testify that they favored this idea. Thank you.
Thank you. Griffin? Anyone else?
I have nobody else at this time, Senator. If anybody wishes to testify, please raise your hand or press *9 if you're calling in on the phone. I see no hands, Senator.
Then I'll close the public hearing. Senator Bradley read that list of bills that he intends to exact very quickly. I only got a few. Kirsten or Griffin, did you have that list?
Yes, I do. I can read it to you here. He said 378, 479, 357, and 582.
Okay.
Was it
Senator Gray?
Yes, sir.
7?
I'll recognize Senator Sherman first.
I'm going to have to jump off again for another prime in probably about 5 minutes. They're working their way through one of our omnibuses, and they're about one away from mine.
I was going to try to pick a time to reconvene. I was thinking about 11. Senator Whitley?
I think, Kirsten, it was HB 157, not 57.
Sorry.
I would think 11 should work for our timing in the House.
Does that work with you, Senator Whitley? 11?
Fine. Yep.
Okay, and since we can't get input from either Senator Avard or Senator Bradley, we'll recess this meeting, come back and take up an executive session, hopefully at 11 o'clock. And that way we'll give you a little break. And anyone who wants to do research on the bills in the time can do that too. Okay, see you at 11. Hello, Griffin and Kirsten.
So, Jim?
Yep.
The bad news is that I am section 5 of this bill and they haven't even started section 3. So maybe we can get through all of our exec session before.
And Senator Bradley and Senator Avard are finding the same thing, but I don't see Senator Whitley on the call right now.
I can text her.
If it's all right, I know a couple of committee members are watching Senate Bill 133. I am as well. If something comes up for, I think you said part 5, Senator Sherman.
Senator Whitley just came on.
Part 5.
Yeah, I'll let the committee know when a certain part comes up.
Senator Bradley, move to
There
go
we
into
go.
executive session.
Thank you very much, Senator Gray. James is doing a great job at jumping in. I was on a waiting to testify on an omnibus bill that no other senator showed up for. And so even though I was the last one to have to testify, it went to me first. So it was like instantaneous leaving and Jim stepped up. So I appreciate it. So I think we can exec a couple of bills really quickly if everybody's ready to do that. And then Kevin and I can both testify. So is there a motion to go into executive session? It's moved by Senator
Yeah.
Sherman,
Second.
seconded by Senator Whitley. Senator Whitley,
Yes.
Senator Sherman,
Yes.
Senator Avard,
Yes.
Senator Gray.
Yes.
Okay.
Senator Bradley.
Senator Bradley, good. Thank you. Okay, so the ones that I think are ready to go are 378, 479, 157, and 582. None of them, to the best of my knowledge, have any amendments. So unless anybody has them, why don't we start with 378, which is
Move on pass
relative
on
to
378.
what's that? Ought to pass?
Ought to pass.
Okay, seconded by
Avard.
Senator Avard. It repeals the therapeutic cannabis, but it keeps the one that Jerry Knirk is chairing. Okay, any discussion? All right, the motion is ought to pass. Senator Avard,
Yes.
Senator Gray,
Yes.
Senator Whitley,
Yes.
Senator Sherman,
Yes.
and I vote yes. Is there a second motion?
Consent.
Senator Gray has moved consent, seconded by Senator Sherman, Senator Whitley,
Yes.
Senator Gray,
Yes.
Senator Avard,
Yes.
Senator Sherman.
Yes.
Okay. House Bill 479.
Who's going to take it out?
Senator Gray will take it out.
Teach you to ask a question.
Yeah, when you embarrass the chair, of course.
Move on pass on HB 479.
Okay, seconded by Senator Avard.
I just had a one comment on this bill. We had talked about putting PAs in that. Right now it's nurse practitioners and providers, and Gary Merchant brought up the concern, which we have not been able to settle. Hold on one sec, sorry. I think what I'll do is plan to bring this back, the issue of PAs, if it's appropriate to add them to the bill as a separate bill or as a floor amendment, unless you are willing.
We can hold it for a week if you want to prepare an amendment, Tom. I don't have a problem with that.
Well, that would be great, because the only issue is whether a PA can ask a pharmacist, because a PA is a supervised position. Can that supervised position then ask a pharmacist? I just don't know the answer. We have a query into the department, into the Board of Medicine. So if it's okay to hold 1 week on this bill, that would be
Okay.
great.
So
Rescind my
Senator Gray,
motion.
do you withdraw?
Yes, I do.
And Senator Avard withdraws. Okay.
Can I make a motion to pass on House Bill 157?
Seconded by
I'll second.
Senator Avard. Okay. Any discussion? Seeing none. Senator Whitley,
Yes.
Senator Avard, Senator Sherman,
Yes.
Senator Gray.
Yes.
Okay, and Senator Me says yes. Senator
Move
Whitley
consent.
moves consent.
Second.
Right. Seconded by Senator Gray. Senator Whitley,
Yes.
Senator Avard,
Yes.
Senator Sherman,
Yes.
Senator Gray,
Yes.
and I vote yes. Okey doke. And has everybody
take
taken
that.
a bill out? All right, Senator Sherman will take that one out. And the last one is House Bill 582.
I'll move on to pass on 582.
Okay,
Second.
seconded by Senator Sherman. Any discussion?
The one thing that I have in my notes is, okay, the bill is changing from 60 to 90, so my notes are fine. Sorry.
Okay, no worries. All right, the motion is ought to pass. Senator Gray,
Yes.
Senator Avard,
Yeah.
Senator Sherman,
Yes.
Senator Whitley.
Yes.
I vote yes. Motion for consent.
So move.
Senator
Second.
Gray moves, seconded by Senator Sherman. Senator Gray,
Yes.
Senator Avard,
Yes.
Senator Whitley,
Yes.
Senator Sherman.
Yes.
Okay. I think that's it for the bills
Yeah.
today.
You want
Do
that on
you
consent?
want me to take that one out?
Yes, go ahead.
You
Senator
want,
Whitley will take that one out.
remove that for consent or are you just gonna take it out?
No, it's consent.
Oh.
Right?
Yep.
Okay. So we need a motion to come out of exec.
So moved.
Moved
Second.
by Senator Sherman, seconded by Senator Avard. Senator Gray,
Yes.
Senator Avard,
Yes.
Senator Sherman,
Yes.
Senator Whitley,
Yes.
and I vote yes too. Okay. So just for next week, we still have a few bills, and I think I'm going to spread them out over 2 weeks, and by then we should be done our House bills. Okay?
Move to adjourn.
Second.
All right. Senator Gray moves to adjourn, seconded by Senator Sherman. Senator Gray,
Yes.
Senator Whitley,
Yes.
Senator Sherman,
Yes.
Senator Avard,
Yes.
and I vote yes. And we're out in 7 minutes, record time.
Azza.
Yeah.
Okay, see you all tomorrow.